The webcast will begin in 3 minutes. The webcast will begin in 2 minutes. The webcast will begin in 1 minute. Welcome to the Leukemia and Lymphoma Society of Canada's webcast called COVID-19 Caring for a Chronic Cancer at a Distance. In this webcast, Scott Bellerby, an outpatient hematology nurse, will speak about navigating the new normal and providing care for chronic cancer patients during a pandemic. Scott will share his experience in the challenges faced in clinics during the COVID-19 pandemic, as well as discuss what the future looks like for healthcare providers caring for patients with a chronic cancer. My name is Sonia Muro. I'm the Community Program Coordinator for the Leukemia and Lymphoma Society of Canada. I will be the host of this online event. During the webcast, you will hear only my voice and the speaker's voice. The presentation will last approximately 40 minutes and will be followed by a 15-minute question and answer period. You can ask questions by using the question or chat functions in the GoToWebinar panel. This presentation is also being recorded. Therefore, you will be able to listen to it again on our website while following along with the PowerPoint presentation. We will send you an email when the recording is available. At the LLSC, our mission is to cure blood cancers and improve the quality of life of those touched by a blood cancer and their families. We offer guidance and support every step of the way. We offer a variety of educational resources and services for those affected by blood cancers, as well as for healthcare professionals. In addition to information booklets, fact sheets, and videos, we also offer valuable services such as the 3rd Annual National Leukemia Conference, a peer support program, and access to our community services managers in every region. Visit llsccanada.org for more information. What can we do for you? We offer free tear pads to facilitate patient referrals to LLSC. Moreover, we are growing our healthcare professional virtual training roster. To know more about these training webcasts, visit llscanada.org/webcasts for healthcare professionals. We know the current situation presents many challenges to those affected by blood cancer and their families. The community services managers can help. They are compassionate connectors that can help those affected by blood cancer cope with anxiety and isolation during these times. Please do not hesitate to refer your patients to a community services manager in your area. It is my pleasure to introduce our speaker today, Scott Bellerby. Scott completed his Bachelor of Science in Nursing in 2010 after completing the Grant MacEwan University of Alberta program in Edmonton. He kicked off his nursing career at the Cross Cancer Institute in inpatient oncology and worked there for 7 years. After this, he spent some time in Los Angeles, California, working on inpatient oncology medicine and soaking up the sun. Currently, Scott resides in Calgary, Alberta, and works at the Tom Baker Cancer Center. His role here is an outpatient hematology nurse, as well as serving on several committees centered on improving patient care and positive change in the center. Most recently, he was involved in the design stages of the new Calgary Cancer Center that is currently under construction. Over to you, Scott.
Thanks for that introduction, Sonia. All right, so I'm just going to do a quick overview of what the presentation is going to go like today. We're quickly going to go over what chronic and acute cancers are, and then I'll get into what life is like in our clinics pre-COVID-19. And then, of course, with COVID-19, what some of the changes were in our outpatient clinics, and then some of the challenges for our patients. And then also, it's important to touch on what challenges were for staff. And then we can go into actually some of the benefits of what the situation, and then going into what our current state is and looking towards the future, what the changes might be with outpatient hematology, and a little bit of advice for both patients and for staff. So there's a lot of chronic cancers that we deal with at the Tom Baker. There's a whole list here. I'm not going to go into each one of them, but it's important to, I guess, just as a resource to have these cancers that we're looking at. So how do chronic cancers differ from acute cancers? So first, we can look at acute cancers, and most of these cancers, the cells are rapidly replicating. So things come on really quickly. The symptoms are usually really obvious and significant in a shorter period of time. They're usually really life-altering in a significant way that the patient feels right away. And it's the most important part is we need to treat this really quickly to avoid the disease spread. This treatment is usually given in a really short period of time when we compare it to chronic cancers. But again, the main point here is that we need to have quick intervention. It's critical to start something. On the other hand, chronic cancers can be a little bit different. So we usually have more slowly replicating cells, and there's slower progression. A patient coming in may feel fine, and the disease may have been discovered incidentally, meaning they're going for their annual blood work at their doctor's office, and there's some counts that are not quite right, and that's investigated further, or possibly blood work before surgery, or if there's an accident. Sometimes those chronic cancers can be discovered that way without the patient feeling awful at all. They may or may not need treatment right away, which is important. So one of our challenges with chronic cancers in general is having someone come in with a new diagnosis and our healthcare team saying, yes, you do have this cancer, but right now we don't need to do anything about it. And that sometimes is a bit of a challenge for people to accept. When the treatment is initiated, it can usually be given over a longer period and in an oral form. And if we need to do subsequent treatment later on down the line, well, that can change things. But in general, patients are likely to have minimal impact on their lives, and they can continue living on with these chronic cancers and doing everything that they did in their lives beforehand. So pre-COVID-19, I'm just going to briefly talk about how we had our clinics kind of set up beforehand. With most of our clinics, we had in-person visits for about 95% of our patients. So arbitrary number there, doesn't really mean a whole lot, but I would say around 95% of our patients we were seeing in the clinic, and maybe 5% that we were managing outside of the clinic. And those exceptions are people that are far away from Calgary, from our cancer center, or people that may have forgotten their appointment, people that may have really a lot of challenges getting to the center. Could be financial, could be mobility. All of these issues, you know, we can say like, all right, if we call you up and say, hey, you forgot your appointment, you did your blood work, but you're okay, you're not on treatment, we can see you a little bit later. And just quickly for those people that don't know, the general flow of how we see a patient, how it starts is we'll get an initial diagnosis from either a family doctor or again, maybe an ER or something. They're referred to us. We have an initial visit where we see the patient as a new patient, and we can do more testing. If we need to do biopsies or imaging, we can get that all lined up. From those investigations, we can kind of determine, okay, what is the best treatment going to be for this patient? Is it initiating some sort of chemotherapy? Is it doing a watch and wait? Is it looking at a clinical trial? Is it maybe heading towards transplant? So once we get all that information, we can kind of compile it and then use our judgment to decide what the next steps are. Then after we decide, okay, sure, we're going to treat this patient, we look at doing follow-up treatments or follow-up visits as the treatment goes along. So before each cycle, we'll see the patient in clinic, make sure their blood work looks okay, make sure they're handling the therapy all right, their side effects are okay, make sure they're doing mentally well with whatever we have initiated. And then ideally treatment completes. We're doing more follow-up visits at extended intervals. And then ideally in some cases we can discharge this person back to their GP and they can come back if there's any issues, or other cases we'll follow them at increasing intervals for quite a long time. So having people in person obviously is the best option that we have. There's a lot of benefits of it. So for our labs, really, really important in hematology. We use a lot of our decision making off the lab values. Having a lab available at the hospital is critical. So people will come in all the time and they say, you know what, Scott, sorry, couldn't get into a lab. I forgot, didn't do my lab work. Okay, no problem. We'll send you the lab right away so we can use that information in our visit that day. On the other hand, too, labs are really, the lab, doing blood labs is really important because in our assessment, we may need to say, well, we did blood work a week ago. It looks okay, but your status has changed in the last week. Let's send you again to the labs, get the best information we can for that day, and then continue on with our assessment. Obviously, a physical assessment where you can see and hear and talk to the patient is the best way to really get a good idea of what's going on. We can look at, is there lots of bruising? Are there lumps and bumps? Having any other issues? Has their mobility changed? Those physical assessments in person are really valuable, and generally, obviously, it's the best way to get a good idea of what's going on with your patient. It's really great to have patients and family there with your patients as well. Having family members there offers another set of eyes, another set of ears, as well as another person to answer questions for you. So there's been a lot of times I'll talk to a patient who's maybe elderly and I'll say, how is your energy? How's your appetite? And they'll say, oh, it's fine. And they'll have a family member jump in and say, well, that's not really true. So having someone else there to answer some of these questions that maybe your patient might not realize there's been a change or doesn't want to tell you, that extra person in your visit is quite valuable. In our clinics, we work with a lot of interdisciplinary teams, and they're critical for making our clinic work really well. Our pharmacy is one of our teams that I use all the time. They're so good with education, initiating treatment. They're so good with our med reconciliation. So going over with the patient, what medications are you on? What's changed? Looking at interactions, things like that. So can't say enough good things about them. Clinical trials, the clinical trials nurses are excellent in our center as well. They'll come in, and if our doctor decides, maybe a clinical trial is right for this patient, they can come in, do the education, get consent signed in person, and then we can initiate a little bit faster rather than doing things back and forth if they're not there. Social work we use as well. Sometimes with a patient that comes into clinic, we can call them, get them to come down. They can set up our patient with financial assistance, If there's issues getting back and forth between the center and where they live. Psychology as well is really important. The psychology team can come down and take care of acute issues that are immediate in hospital. Now, typically what we'll do is we'll refer out a psychology assessment after the visit. But if there are these critical issues that need to be taken care of right away, they're great at coming down and assessing that. Diagnostic imaging kind of falls under the same umbrella as our labs. If we're doing an assessment, we see something or we're not really sure about something, we can initiate maybe an x-ray or ultrasound and get those things done a lot faster just in hospital. One of the resources we have that's really handy is a language video chat where basically we have an iPad on a little dolly that we can wheel around and we can do a video chat with an interpreter. And if we were bringing in patients into hospital, maybe them or their family don't speak English that well, it's excellent to use to really get the point across in their own language, what's going on, answering questions in a way that's going to work for them. So COVID-19 in 2020, not ideal. I cannot stress this enough. It was never a good idea, but we're here now. So how do we respond to a global pandemic? It's a great question. The last comparison we have is a lot of people have used as the 1918 flu pandemic, and there aren't a whole lot of people around that went through that. But there's a lot of differences between what that pandemic was like and what this one is like. And number one is the way that it's spread and travel. And right now we have so much travel with domestic travel, international travel. We have air travel, boats, planes, trains, whatever, however you're getting around. There's so much more of it now than there was back then. The other thing too is different is the media. So right now we're in a society where any information is available. The touch of a button, it's in your phone. You can look online. That's great for a lot of reasons, but that also can result in too much information that might not be right, or information coming from sources that might not have the right idea, we'll say. So there's many unknowns with this global pandemic. As it kind of came out, a lot of the message was, this is just the flu. Don't worry about it. It's just the flu. The flu that kills X amount of people every fall. This is not even close to that. Don't even worry about it. Why is everyone getting bent out of shape about it? But as we kind of went through 2020, things changed, and they changed again and again and again. And I feel like there was a little bit of ignorance in Canada as far as, well, this is not our problem here. This is over in Asia. It's a flu. I don't know what they're doing over there, but this can never happen to us, and we're safe here. But things kind of changed and progressed as the months went along during the year. And we had to make a lot of adjustments to our entire healthcare organization, which we'll get into a little bit later. So one of the problems that we need to look at as well is just a little bit of the psychology of all these changes and all of these issues that are coming up with COVID-19. So the human mind deals really well in black and white issues, the lights on, the lights off. There's not a lot of uncertainty there. There's not a lot of ambiguity. But with COVID-19, and especially how it developed over the months, there was a lot of issues about getting the right information and getting information that was concrete, which again, because of all these changes, a lot of people had, fairly had a lot of trouble understanding exactly what's happening. What are the risks? What should we be doing? But why does this matter with this ambiguity? So when we're establishing changes in our policy and our behaviors for our patients, we're starting off with some incomplete information, and we're using a lot of worst case scenarios of this might happen, but let's try to keep everyone safe. But for a lot of people, that doesn't really hit home for behavior change. So we're getting this information, or people are telling us, if we're saying like there's an 80% chance or a 60% chance, our behaviors don't really change that much in there. But if we say, again, if the light's on, the light's off, we can experience that, and we know that we don't have that ambiguity. It's a yes or no, black and white sort of situation. And again, I'll get into this a little bit later, but this is just some of the things to remember that why the behavior change is a little bit difficult. So what are the effects on patients in the outpatient setting? As we just kind of touched on, there's a lot of ambiguity on what is going on, what's happening. Things were changing week by week as, you know, when COVID-19 first started, or as it kind of hit North America. And what was expected by patients was not really known as well. The professionals in healthcare in the clinics were trying to figure out, how do we manage our clinics the best way? Who do we need to see? Can we move people? What are we supposed to be doing? But not all of that information is being passed on to patients. So they're at this point left a little in the dark, because if we don't really have a solid understanding of what's going on and what's expected, how do we expect our patients to? Noticed right away a lot of our mental health concerns increased. Not only was there fear of getting COVID-19 itself, which is a legitimate fear. I'm sure everyone in the public had, or everyone listening to this had a couple moments where you're thinking, well, I'm gonna get it for sure, I'm in healthcare, or worried about your friends or your family. There's also the fear of not being cared appropriately. As we're looking at moving people out or changing our model of care, sometimes our patients were saying, well, if you're not going to see me, how am I going to be taken care of? And am I going to be left, lost in the shuffle? There was a lot of anxiety with that again. A lot of anxiety with the unknown. How are we going to be seeing people? How are we going to be people coming in for treatment? How are we going to manage things with the months going forward? Another one that we noticed, and I think this one kind of increased during the later stages of lockdown, was the loneliness aspect. So we have a lot of our population is 60 to 75 to 80. They're at home alone. Now we're telling them, you can't have visitors, can't see your family. We have to have you stay inside on lockdown because you're at a high risk. You're at high risk for getting this and then spreading it to the people that are around you. So there was a lot of loneliness and stress from that social isolation. In our center, or I guess in any center at all, there were policy changes that we needed to follow. So these were relatively frequent, and that is an inevitability when we're dealing with something like on this grand of scale. So as our global knowledge increased and progressed, and the best research became available for us, we needed to shift, and we needed to kind of look at what our practice was and say, okay, this is not going to work. We're going to change it to this process. Okay, great. And then maybe that process wasn't the most efficient way to do things, so we needed to shift things around again. So we were learning a lot on the fly while trying to take care of our patients really well. So again, more of the response to the COVID-19, we everywhere implemented intense hygiene practices, and this did take a little bit of time to catch on. Number one was the masking. So there's questions about, when should I mask? What mask should I wear? Do I have to have it at home? Do I have to have it outside in the hospital? We implemented strict hand hygiene policies, which not only for staff members, but for the public coming in. A lot of these were kind of implemented at our screening points. So there's a couple. We had our screening prior to our visits, where we would call patients and say, go through our screening questions as far as travel, symptoms, and exposure. And then as well, we would do this again at the point of entry into the hospital with staff and with patients as well. We also looked at limiting our visitors in the hospital. So unfortunately, our volunteer staff, or people that weren't required to be there, they weren't coming in. And that's the volunteer staff. It's important to remember that they are actually big players in our clinic. The patients love them, the staff love them too. They're incredible. We really miss them. But for right now, limiting that volunteer staff is most beneficial for everyone. With limiting our visitors, that was quite stressful for patients as well. And we'll talk about that a little bit more in depth later on. But limiting the visitors for patients. We would have, inpatients, they shut down the visiting, people coming in with their family members to an outpatient clinic. That was cut really short, as well, people coming in as new patients. We used to say you can bring your family, but we had to really limit that going forward. So another thing we did in response to COVID-19 is we were looking at avoiding visits as much as possible. So for myself, with some of my doctors, what we looked at first were really short-sighted. We said, let's move these people a month or two down the road, wait till this clears up, and then we can see them again. And we soon realized that is a flawed plan. It's not going to happen. This is going to be around for a long time. So we said, okay, now we're scrambling a little bit. We have these overloaded clinics. How can we look at taking care of our patients without actually seeing them? So we looked at moving right towards virtual visits for most of our patients, which is a big switch. When we started, some of our treatment patients, again, that we knew that were doing well, that were relatively low maintenance, we would say, okay, we're going to just see you, we're going to talk to you over the phone. You can come in, do your treatment, and if there's concerns, we could talk about it then. So luckily for us, hematology can kind of accommodate these circumstances. Most of our care, we have a luxury of predicting care depending on results of blood work and lab values. And it is not the whole picture, but it is a large majority of the picture. So we can utilize the information we get from people going to their local labs or getting their blood work done and then doing a phone visit. And through our lab values and the conversation, we have a pretty good idea of how these people are doing. Again, our clinics changed mostly from in-person visits to primarily phone visits. And those people that were coming in, they were either really sick or needed a lot of education, or they may have just said, listen, I gotta see the doctor. And we would say, all right, if there's something going on, bring him in. Let's see what's going on. All right. So in utilizing technology, we switched to a lot of virtual video. We did some virtual video appointments either through Zoom or Skype, and this is available. If you have that technology available at your center, great. The only issue is you need to have that technology and the person to be proficient with it on the other end too. So most of our appointments or virtual stuff was done over the phone. There were a small amount of email communication going on as well. If your center is comfortable with that, great. It didn't really work for a lot of our patients. Again, with some of our patients, it's really easy. If you have someone who is young, just out of university, they can do a lot of these. They can work with the technology. They have those resources. But if you're talking to someone who's in rural Alberta, who's been on a farm their whole life, doesn't utilize technology, that becomes a lot more complicated. So that's one of the big challenges is we can use technology, but we need to implement it in a way that the other person on the other end can utilize it as well. So there's our patients coming into our clinic. So these patients, again, that are either quite sick or they need to be seen before treatment, or they're a new patient. We had to implement a lot of changes with them coming into clinic. So again, we talked about the screening questionnaires and temperature checks at the doors. Now this didn't start initially, but as we got more information and as we were looking at the stats and strategies on how to limit exposure to people in the hospital, that's one of our best ways, just to say, okay, if anyone is coming in with a cough or a fever or any of these COVID-19 symptoms, we're going to take initial action and isolate these people away from everyone else so we can do our assessment that we need to do and then carry on with their care as we need, again, using that precaution. Masking for everyone. Obviously, if you're coming into the hospital now, everyone's wearing a mask if they're not 6 feet away from someone. This is not strange to see anymore, but initially starting that, there was a lot of pushback from people saying, well, I don't need to wear a mask, I'm fine. Or, we're in a hospital, why would I need to wear a mask? Or I can't wear a mask because whatever the thing was that they couldn't wear a mask for. We did implement, obviously, social distancing. That's a general societal thing as well, and we do implement it in the hospital as well. Crossing out chairs or making sure people are waiting, they're waiting a certain distance apart. Lunchrooms too, we're removing half of our seating area. There were changes in the flow clinic as well. Waiting between patients to properly clean the rooms and the equipment. Sometimes that, even though our clinics were smaller with people coming into our clinics, that flow was interrupted a little bit, so we needed to space out our patients a little bit more. Again, one of the biggest changes that people found that was the hardest was limiting visitors and accompanying family members. Really hard when we're trying to deliver news that might not be great. It's really hard as well looking at just seeing that patient who might not remember everything that you're trying to assess, who may be downplaying things, who might just be, really upset that they can't have their family members in there with them. So what do we lose when we go to a distant care model? So challenges between patient and staff interaction. Number one, it's going to be our communication, our body language. So there are stats out there saying body language accounts for 90% or 35% or 55% of your communication. Don't worry about the stats. The important thing to remember is you're losing a bit of your communication by not seeing the person in clinic. You're going to be losing if they say, like, I'm fine or I'm fine. Those are two different messages that are being sent. So we're losing that by not seeing the patient in person. The environment for the patient and staff as well. So this is an issue as far as trying to assess your patients. So if we're now changing our model from, we're seeing you in a private, quiet room in the hospital where it's the healthcare provider and the patient. Now we're switching that to, well, we'll call you. Well, I'm calling you from a clinic area that might be quite loud. There might be people bustling around. There might be people dropping me off paperwork as I'm trying to do this assessment. On the other end, you might have kids at home. You might have the TV on. There might be other people mulling around, not realizing what's going on. You might not be able to have that privacy that you want in your conversation. The flow of the conversation changes as well, where, again, if you're talking to a person face to face, you can tell whether there's hesitation or they might be unsure of things, or those cues that you want to dig in a little bit deeper with your assessment. And you might not get that over the phone. A challenge for us is directing the purpose of conversations. Again, there's a lot of reasons for this, but these people, if they haven't been seen by anyone for a long time, they're stuck at home alone. When you're calling them, you need to determine, okay, hey, Mrs. Smith, this is Scott from Tom Baker. I'm calling you because we need to go over some of your questions before the doctor talks to you. Now, sometimes that goes really well. Other times it becomes kind of a social conversation, which you really need to steer in the direction of, I'm here to do an assessment on you. Not seeing a patient in clinic prevents relationship building on a personal level. So I've had patients that we've seen initially in consult, and then I've talked to them on the phone a lot, but you don't really build the same rapport with patients as the ones that you're seeing in hospital or in clinic, I should say. At times there are language barriers where even if you're with a patient and you're using an interpreter, you're building that bond a little bit of that interpersonal communication. At times you're speaking through children or caregivers over the phone, you're one step removed from talking to that patient. And sometimes that can be a bit difficult. Talk about fears and anxiety. Comes up again because it's really important. People are scared about the situation and not knowing what's going on, and that ambiguity that comes back again of, well, when is this going to end? What's my risk for COVID-19? So there's the risk, there's the fear of getting COVID-19, again, the fear of being left and falling through the cracks. So that exposure to the disease and that fear of not being taken care of. We have competing fears here and competing ideas that we need to somehow in the middle find a common ground. There are educational challenges. Again, I'm going to go back. Our pharmacists are awesome at talking to our patients about medications and treatments and what the side effects would be, and what their cycle is going to look like, their pre-medication, and we're giving them resources right there in person to say, okay, this is what this pill looks like. This is where you're going to take it, and that's awesome. And our patients love it. When we're doing it over the phone, we lose a little bit there. If we have to teach skills like teaching a patient to give themselves a subcutaneous injection, that is tough to do without them being there in hospital. So we need to arrange for them. When we could do it in a clinic, we need to now arrange for them to go to their pharmacist or come in and see us, and we can teach them. So it's a little extra step. Vulnerable populations are quite a challenge as well. People with no fixed address are sometimes hard to get a hold of. If they're living in a care home sometimes, or maybe a homeless shelter, those people are really hard to kind of get a hold of. And social work does a really good job of kind of tracking these people down and helping them along the way and being a bit of an intermediary for us. So that's awesome. People that are working as well. I touched on this earlier. There's a lot of people who have this, who might have a chronic cancer, but they're able to work. They're out there doing their job, and they're not always available. I know I'm not always available when I'm at my job, but we need to also take that into consideration. And again, technologically challenged people, it's always going to be a problem. There's certainly underreported symptoms or concerns when we're doing these issues over phone, or doing these visits over a phone call. It could be a situation where the patient doesn't know it's an issue, the patient doesn't realize there's been a change, the patient doesn't want to make a bother, they understand that there's the COVID-19 situation going on, they might be scared and they don't want to say anything to have them come in. A lot of the times we can take care of these concerns really quickly when they're in clinic, but if they're not in clinic, we need to maybe deal with them down the road when they're a little bit worse. Changing our care model from a patient as a family unit to a patient individual has been a pretty challenging change as well, because we're really shifting the responsibility quickly from us looking at a patient and saying, you know what, you're here with your family, you have so much support, bring your family in. They can take notes, bring your caregiver in, mothers, daughters, sons, any family member, bring them on in. And now we're saying, actually stop that. We're going to actually just see you on your own, and please make sure that you can handle all this, which a lot of patients can't. There's a big responsibility that we're shifting from the family just directly to the patient, the one that's, might have side effects, might have memory issues, might have brain fog related to treatment, might be elderly and not be able to retain everything. And that shift is really difficult for the patient and for the family. We'll have follow-up calls from the family. My dad was in the hospital, or my dad came to the clinic. I'm asking him these questions. He doesn't really know the answers. When is his treatment? When do we need to do blood work? All these questions that were once managed by the family are now kind of put on the patient, and we have to say, all right, it's time to step up. You need to manage this a little bit more on your own, which is not always fair. This is a great picture. I love this. This is exactly what I look like in clinic most of the time. So what are the challenges for patient-staff interaction? So one of the biggest ones we found was our referrals to allied health. They declined a little bit. So we needed to look at different ways to keep providing these services in an effective way. So that's an important thing to remember, that again, when it's underreported symptoms, or you're not necessarily seeing the patient and being able to pick up on some of these subtle changes or these subtle concerns that your patient will need, they still need to be followed up, and you still need to access the services for them. Going through procedures alone is pretty tough for patients too, and for staff. I mean, if you're seeing someone going in for either a bone marrow biopsy or some sort of procedure, they're scared. They don't have any family members. So now the patient is really quite stressed, and staff need to address that as best they can with the patient being alone. Stress levels are at an all-time high for sure. So for staff, these are some challenges for staff with this whole thing. We can't just say this is just a patient-centered issue. For sure, it's not. So health concerns for self and family and friends was really big as well. So as COVID-19 started, again, that ambiguity comes back of we're not really sure what are the risks. We're not really sure about, if I am working in hospital and I get infected, what's going to happen? How do we manage that? And of course, there's an added stress now of people who are coming into hospital and that have a passion for caring for patients, but you also are having to think, now when I go home, what risks am I bringing home to my family and friends? So that's an added stress. The policy changes we talked about a little bit, and there's been clear communication from our organizational lead down to frontline staff. Lots of, it's important that your team can say, here's the changes we're doing, here's what we're doing, or here's what we're looking at, and disseminating that information among your team. The great thing too is that we've had a lot of open communication from our frontline staff up to our executive level for us to say, hey, this change is not really working well, or maybe we have a better way of dealing with these issues from frontline staff. And that open communication up and downstream is critical. I have had some other nurses talk to me when I was kind of gathering some information about what should I talk about. There are feelings from staff members about a little bit of guilt about having to be a police our policies as well as provide care. So when we're having these challenges, for instance, say someone didn't want to wear a mask in hospital or someone refused to come in without their caregiver, well, we need to look at the situation and say, what is the best way to serve the patient here? But also, what is the best way to serve everyone else at the same time? So that ambiguity of the role was quite difficult as well. We're trying to educate our patients and families about why these changes are happening. Again, the problem with a lot of these changes are what was true for week 1 might not be true for week 3 of whatever. These policies are changing, and we need to continually educate our patients and family members on why the changes are happening. A critical thing becomes significantly more important for staff. There's a steep learning curve for new procedures and policies and how to manage patients. If your patient comes in with a cough, what do you do? Well, here's a flow sheet, and this is how you take care of them. But critical thinking is also really important here, because while nurses often operate on incomplete information, we're doing that in a more significant way now with not seeing our patients. So we're using as much information as possible that we can gather, trying to disseminate it, trying to come up with the best solution, and then going forward with our best foot forward with the information that we have. So a bit of shifting responsibilities. Again, this is a concern that was brought to me by a treatment nurse, actually. So there are changes with not seeing patients in hospital. Sometimes these responsibilities shift to other staff members, sorry. So treatment nurses often can see patients and they're dealing with questions and concerns regularly. However, when we are implementing this situation where we're seeing people from a distance, those concerns sometimes come in when the patient's getting treatment, and then they bring those concerns to the treatment nurse. And they may not always have the resources, the time, or the knowledge to deal with all of them. So there's a lot of communication back and forth, bit time consuming, sometimes a bit awkward. But if we're seeing patients in clinic, then usually we can kind of start that intervention earlier. Another good another challenging subject is, how do we manage learners in clinic? So that could be new staff, it could be a resident, it could be a fellow. How are we looking at, how do we manage these patients, or how do we manage these learners in a situation where we're saying, this is not typical, but this is how we have to do things now due to COVID-19? If someone's a lymphoma patient, can we really feel, we can't really feel what their lymph nodes are like over the phone. We can have people come in, but again, we need to, the learning aspect is a bit challenging for those that maybe don't know hematology or don't know outpatient setting. Communication between team members is always a challenge. I think it's become far more important with seeing our patients from a distance. The best way to take care of this is clear charting. So, you get a call in from a patient or you're calling a patient, make sure we're documenting that interaction and make sure you're saying, I addressed this, this concern is still pending, we'll address it next week. So that way, if someone else picks up a call that someone's called into the center for, they have an idea of what's going on and they have a good plan going forward with how to address this. So managing our treatment toxicities and side effects from a distance is challenging. Our pharmacy team does a really excellent job of following up after cycle one of any sort of treatment, saying, how are things going? Are there any issues? But again, from distance, we're looking at treating things a little bit reactively rather than being proactive sometimes when we can see a patient in our care. Time management concerns, they're not new. Nurses always have time management concerns, but they are becoming more important now with you changing the way we're doing things, and not only taking care of a full patient load, because the patients are still needing to come in, or the patients still need care, but we're looking at implementing new systems or doing different interventions that might be more time consuming. So that's a bit of a concern and challenge for staff as well. There's been increased phone calls to telephone triage and clerks. Again, if a patient calls in or if I'm doing a phone call with a patient, we address their concerns, but maybe they forget something, and right after the conversation, they've got to call back to our telephone triage or other clerks or things like that. So there's a lot more telephone traffic, I should say. And as well for staff, stress levels are all-time high. What do we gain? So this is an opportunity to look at our clinic processes and mold the clinics with our providers to adapt to our current demands. Asking questions like, do we really need to see everyone in clinic? What are the appropriate intervals that we're going to see people? Can we implement different technologies or different strategies? What do we do with our out-of-town low maintenance patients? Well, there is opportunity to kind of change the way that we're looking at our clinics and implement those changes. There's been a gradual increase in our patient participation from my view. I think with COVID-19, they're a little bit more aware of, okay, I need to get my blood work done. I need to buy into this system. I need to really take a little bit more of a responsibility with my health. And again, overall, a global increase in hygiene awareness has been probably the biggest benefit of COVID-19. Never has there been a time where people are so good at washing their hands, wearing masks, and really looking at, am I sick? Well, I'm sick, I'm not going to go into work. So things like that are actually a benefit. There's certainly more attention to mental health concerns. With this stressful situation with being isolated and this looming COVID-19 pandemic, people's mental health is not as good as in the good old days, and sometimes you need help, and it's important to ask for help when you need it. And I think there's normalization of mental health resources that's becoming more normalized. It's not becoming as taboo, and it's a great change. We're increasing your utilization of our community-based resources. So things like mobile lab services, where we have a lab go directly to a patient's house, or we're able to possibly have community paramedics go directly to the patient's house and give them blood instead of having them come in. That's a great intervention as well. As we are going through COVID-19, we're having a gradual acceptance of changing behaviors regarding masks. And it's because what we're having is where we started off giving a lot of information and saying, like, yes, there is this ambiguous risk of COVID-19. Slowly, we're changing behavior where we're seeing masks everywhere. Everyone's washing their hands, so that people are experiencing it and then changing their behavior because of the experience, and not necessarily the information, but because it's becoming more normal. So our current state, COVID-19 definitely remains a concern. There's concerns about possibly a second wave. Most of our patients are being seen virtually. Again, our PPE and our advanced hygiene principles are becoming more normal, So this is, again, a net benefit. We're looking towards changing our care model a little bit, where the nurse and the physician each have their own assessments to follow over the phone. Sometimes it's done concurrently, sometimes it's done independently, but we're working at looking and see what's the best situation we can do for these patients. Now we also have we're implementing a system. I should say it's been live for quite a while now, but we're getting patients more to buy into this, where there's access. You can have access to your blood work online through a provincial portal. It exists in BC. It has for a long time. Alberta has been implementing it and getting more people on board with it. So just moving forward, there's some questions that you can ask yourself and ask for your own practice. And I don't really have answers for these, but you can take a look at these questions and just say, yeah, moving forward, the game's changed a little bit. What are the changes we can look at going forward with our patients and with our clinics to really utilize the benefit of the silver lining of this whole situation and really assess what some of these interventions are? So advice for our patients: number one, open communication. That's the biggest one. So if you're feeling sick, if you're feeling ill, let us know. If there's issues, let us know. If you're having trouble with your mental health, let us know. So when you're talking to your patients and they say, what can I do to be the best patient ever? You can tell them some of this stuff. Please do your blood work when it's scheduled. Shocking how many people don't want to do blood work or forget to do blood work, which is really quite important in hematology. If you are doing virtual visits, try to manage your environment with the intent of making the visit as valuable and as efficient as possible. Keeping in mind that nurse on the other end has 16,000 things going on in the background. Use a journal at home to track your side effects or symptoms. If we can't see you, maybe using a journal will allow you to kind of track and say, you know what, I have been feeling a lot more tired lately. I have had a lot more bruising. Whatever that concern is, you can kind of track it a little bit. So for healthcare workers, open communication with patients and other team members. Patients are smart. You gotta give it to them straight sometimes, where you're saying, like, listen, I don't know what's gonna happen with COVID-19. We're gonna manage it day by day. In 2 months, we'll see what the situation's like. I have no idea what it's gonna be like. And we didn't in January either, when we were making small changes to wait for this to blow over. Concise charting is really important as well. It's just becomes more important when there's a lot of people that are looking at your charting to say, managing this patient from a distance is not easy. So how do we get the best picture without seeing them in clinic? And a lot of that comes from really good charting. If you can, talk to your patients about the expectations of a virtual visit, and if you can talk to them beforehand, great. If you need to talk to them at the beginning of the phone call, and that is great too. But sometimes patients want to have a bit of a social visit too, and that's okay with some patients, but I know with my time it's pretty limited, so I won't be able to do that with every patient. So just kind of manage that expectation. Last one is take care of yourself first. Really, really important to take care of yourself and to really assess how you're feeling with COVID-19, how you're doing mentally, physically, spiritually, whatever you need to look at. Make sure that you're managing your own health first, so you can be a good caregiver. So I found a really good quote here. So rest and self-care is so important. When you take time to replenish your spirit, it allows you to serve others from the overflow. You cannot serve from an empty vessel. And that is just some more resources about COVID-19 from Lymphoma Leukemia Society of Canada. And now we're ready for questions.
Thank you so much, Scott, for your expertise and your insight today on the current situation in our cancer centers. It's very much appreciated. So it is now time for our question and answer period. Please remember, because there are many of you, we ask that you ask your questions using the questions or the chat function within the GoToWebinar panel. All right, so Scott, our first question: how can we include kids affected by cancer and their families in this long distance caring?
So with kids and cancer, it's it's a bit of a tricky question here. So we're looking again as kids are your patient, but again, when you're looking at pediatric hematology, pediatric oncology, you're treating the whole family. So it's, if you can, involving the whole family in your online visits, in the information is probably the best way of including everyone in that group. If you're doing a phone call, you know, maybe make it a phone call that a few people can be on, or disseminating the information not only to the patient who's a kid, but the parents who are also part of that group. I mean, certainly there's I don't know what strategies you would use, but having someone who's younger buy into the principles of wearing a mask and doing hand hygiene and making it fun, or making it a game, that will certainly help with limiting exposure and risk of transmission.
Thank you. We have another question. Do you think that the additional fear and emotional strain of the pandemic on cancer patients will inhibit them from actively seeking medical attention, or from being active in their care?
Yes, so that is a huge concern right now, with having people, again, that fear of contracting COVID-19 and the view of hospitals being the place where the disease might be. We're finding that there are some delays with people coming in to seek treatment, and that's especially dangerous in some acute cancers where we need to do those interventions pretty quickly. It's still important in chronic care, in chronic cancers, to seek the medical attention that you need if you think something is going on. Again, there's been no other time where everyone's been so acutely aware of what these hand hygiene protocols are, wearing masks. So helping to kind of get that idea out that, you know what, if you do have a problem, it is safe to come into a hospital. That's really important, to have people come in and be seen when they need to be seen.
Thank you. We do have another question. Do you think that community pharmacists will play bigger roles in the care of chronic cancer patients, specifically for those on oral form of treatments?
Yes, actually. So community pharmacists definitely, I think, have a role here with our patients that are relatively well managed at our cancer center. And if their symptoms are under control, their counts are under control, yeah, those community pharmacists are certainly valuable. In initiating treatment, I would say it's probably better to have the pharmacists at our center be a little bit aware, but you know, I would start it off with the pharmacists that are in a hospital or in a bigger center. And then again, the key is here, if we're having good communication between that pharmacist and the physician, or that pharmacist and the pharmacist who's at the hospital, then yeah, it could certainly work, and it will allow the patient to stay in maybe in the rural setting and not have to come in.
Thank you. Does not look like we have any further questions. So I will move on to the next slide. Thank you so much. So first and foremost, I'd like to thank our partner AbbVie for helping to make this webcast possible today. As well, in 2020, it's been an unprecedented year, and we all know that cancer doesn't stop, and that the need to fundraise has never been greater, and that people really want to help. Although Light the Night has had tremendous success over the last 15 years, we need to adjust our strategy to the current reality. We are so proud to announce that for the first time in our history, we will meet as one community on October 24th, 2020. From coast to coast, our community will come alive to share survivor stories, honor our heroes, and remember loved ones lost. So mark your calendars. The virtual Light the Night broadcast airs 7 p.m. Eastern Time. Please visit lightthenight.ca for more information or to register. I'd also like to remind everyone to not hesitate to contact the LLSC if you need more information or for support. You can reach us by email at canadainfo@lls.org or toll free at 1-833-222-4884. So also make sure to check out our website regularly to watch all our past webcasts and for the dates of all our upcoming webcasts. One more reminder is to please note that a short survey will be sent to all participants after this webcast, and we would greatly appreciate you taking a moment to fill it in, as it would really help us to offer you the most valuable information in the near future. So thank you once again, Scott. It was a great presentation.
Thank you.
Thank you all for joining us today, and have a wonderful day, and please stay safe.